everyone. I am here to present a comparative study between two types of commonly used PFNA II and Zimmer Natural Nail in unstable and intertrochanteric fractures. As we know, with increased life expectancy, the incidence of intertrochanteric fractures are increasing, being a geriatric fractures. This has been traditionally treated with prolonged immobilization. However, with the invent of DHS, it becomes standard of care for this type of fractures. Literature shows a failure rate of about 40% with DHS. Then come the era of sacromedullary nails, which were mechanically advantageous and were reported to be of more stable than the DHS. However, with the increased age of the patient and increased osteoporosis, we are seeing incidence of failure of sacromedullary nails also. The basic difference between these two kinds of implants is in PFNA II we have got a helical plate and it's a straight nail in a sagittal view, whereas the Zimmer Natural Nail we have a leg screw type of head screw and it's a curved nail with a radius of curvature of around 1275 mm. The reported complications in literature with PFNA II are hip pain, thigh pain, femoral shaft fractures and leg screw cutout. The reported complications with Zimmer Natural Nail are superior fracture side opening, inferior femoral head displacement and fragment sliding. Though many studies are done comparing these two implants, one is a finite element study, which is a lab study, and there are many Chinese and Korean studies. However, we don't have any comparative study in Indian population with these two kinds of implant. And there was a study by Sivachetan which showed in 2018 that the proximal femoral anthropometry of Indian population is different from those of Chinese and Korean population. So there is a need of study of this kind in our population. This is the study design after obtaining the institutional review board approval. This was a retrospective study. We calculated the sample size which came around for 31 for each group, which was rounded to 35. Any patients with intertrochanteric fractures of unstable configuration of AO subtype 31A22 and higher with age more than 50 years were included. Patients with pathological fractures, associated fractures in the same limb or a previous fractures around the same hips were excluded. So we started the study, we take the cases for 3 years before starting the study from 2016 to 2019. We measured the primary outcome measures which were failure rate, time to union and Harris hip score, as well as the secondary outcome measures such as operative time, fluoroscopy time, latent hip pain, walking ability and reoperation rates. These are the parameters in details which we have studied. This is the table comparing the preoperative parameters between the two groups. We can see the preoperative parameters were similar between the two groups. There was no significant difference in the preoperative parameters, giving us a uniform study groups to compare with. In the intraoperative parameters, the operative time of ZNN was around 77 minutes, whereas the operative time of PFNA II was around 70 minutes, and this is the only intraoperative parameter which came out significant, with a p-value of 0.0432. Among the post-operative parameters, we had a significant difference between the anterior cortex abutment, which was higher with the PFNA II implant. It was a radiological parameter measured, and the p-value was 0.004. So in the results, there was no difference in the primary outcome measures. There was one case of implant failure with PFNA II, although statistically this was not significant. Among the secondary outcome measures, we find a higher operative time with ZNN implant, as well as higher radiological anterior cortex abutment with the PFNA II implant. Though the incidence of latent thigh pain, which signifies the clinical implication of the anterior cortex abutment, was not difference between the two groups. The limitations of our study, it is a retrospective cohort study. There is always a selection bias in this kind of study, where the surgeon is choosing the implant according to his experience, and we have not considered the cost parameters. The strength of the study is that the preoperative characteristics were both the groups, were same in both the groups. We have a standard postoperative protocol for physiotherapy and anti-osteoporotic medications. We have the same surgical team, and this is the first of its kind of study in Indian patient, though retrospective. In conclusion, we found that there is a statistically significant higher operative time with ZNN as compared to PFNA II. This may be attributed to the reaming step of the ZNN over the guide wire. And despite ZNN being designed to accommodate the intrafemoral bow, as radiologically evident, there is no significant translation of this effect clinically in terms of thigh pain. As regards of the primary parameters, there is no significant difference. This is one of the case illustration of the PFNA implant. This is the case illustration of the ZNN implant, and this is the case of failure which we noted with the PFNA implant. Thank you.